Good day. I'm Laurel Lagenaur, and my presentation is called Connecting the Dots, Translating the Microbiome into a Drug. I'd like to thank the organizers for inviting me to give this talk. My conflict of interest: I'm an employee and stockholder at OSEL, the company that's developing LACTIN-V. Bacterial vaginosis is a dysbiosis of the vaginal microbiome. The optimal vaginal microbiome is low diversity and Lactobacillus-dominant. And whether you look at a gram stain or a bacterial communities plot shown here, you can see that low diversity of mostly Lactobacillus. Conversely, the pathophysiology of BV, you actually see a decrease in those hydrogen peroxide producing lactobacilli. And again, the gram stain and the bacterial communities plot paint a very different picture. We see increased bacterial diversity. This can be accompanied by, it's accompanied by high pH and can have odor and discharge, although bacterial vaginosis may be asymptomatic. Doug Kwong's group at the Reagan Institute found that lactobacillus deficient cervical bacterial communities are associated with increased HIV acquisition in young South African women. In this study, they found that women with lactobacillus-dominant cervical types had the lowest levels of pro-inflammatory cytokines and the lowest risk for HIV infection. Conversely, women with a diverse microbiomes, shown here on the right, cervical types, had the highest levels of pro-inflammatory cytokines, up to 17-fold increase in activated CD4 T cells, the T cells that would be HIV targets, and about a 4-fold more increase likelihood of becoming infected with HIV. So our hypothesis was that lactobacillus dosing, Lactobacillus crispatus in particular dosing, following the standard of care antibiotic treatment for recurrent BV, could also reduce the susceptibility to HIV by creating a lactobacillus-dominant cervical vaginal environment. So our product is LACTIN-V. It is a single strain of Lactobacillus crispatus, CTB05. It's delivered as a powder in a vaginal applicator. In phase 1 studies, it was safe and well tolerated. The phase 2 studies, which I'll talk about today, were sponsored by NIAID and DMID. LACTIN-V targets the underlying cause of dysbiosis, which is a loss of those lactobacilli, and it's an adjunct therapy following antibiotics. The phase 2 clinical trial has already been completed, but if I have time at the end of the study, I'll talk about another trial that's in progress to look at colonization reduction of genital tract inflammation and acceptability in South African women with HIV, with high risk for HIV. So this is the phase 2 LACTIN-V clinical trial outline. OSEL, in collaboration with 4 centers, performed a double-blinded, placebo-controlled phase 2b clinical trial to prevent bacterial vaginosis in women treated for BV with metronidazole gel. Women ages 18 to 45 were screened for eligibility, including a BV diagnosis. Women that completed a course of antibiotics, if then they were eligible, they were enrolled at a 2-to-1 ratio to receive LACTIN-V or placebo for 5 days, shown here, followed by twice weekly for 10 weeks. Women were followed up at 4, 8, 12, and post dosing at week 24, and the primary outcome of the study was women with recurrent BV at week 12. Here's the demographic data of the study. Most of the women, 51%, had greater than or equal to 5 BV episodes. 15 or 16% had 3 to 4 BV episodes. 20% had 1 to 2 episodes, and only 5% were having their first episode of BV. Adherence to the study was about 80%. It's important to note in the demographics that 20% of the women were Hispanic or Latina, and 42% Black or African American, making over 50% of the women in the study in the two populations that are most susceptible to BV. These are the criteria used for BV diagnostic. The clinical criteria of AMSELS, which looks for homogeneous thin discharge, clue cells upon a microscopic exam, increased pH greater than 4.5, and a fishy odor caused by amines from the bacteria associated with BV. And they also used a gram stain or Nugent's criteria, which looks for lactobacillus or other morphotypes. And women were enrolled if they had an AMSEL of 3 or 4 and a Nugent's of 7 to 10. These are the results of the phase 2 trial. In the intent to treat analysis, BV recurrence through the 12-week visit was significantly less in the LACTIN-V arm, 30% versus 45% for placebo, with an odds ratio of 0.54 and statistically significant at 0.031. BV recurrence was also significantly less at week 24, 39% in the LACTIN-V group versus 54% in the placebo group. Again, an odds ratio of 0.54 and a p-value of 0.03. At 12 weeks, Lactobacillus crispatus was detected in 79% of women in the LACTIN-V arm, and what was detected was CTV05, and 3% in the placebo arm, and this was another Lactobacillus crispatus, not CTV05. And this suggests that you need to give exogenous lactobacillus to increase those Lactobacillus crispatus numbers in women. So these are participants in the LACTIN-V arm. Here we have detectable colonization on the y-axis, the study week of visit on the x-axis, and in the second y-axis we have the concentration of lactobacillus. The blue box and whiskers plots show the median concentration of lactobacillus in log 10 CFU per mil, and you can see that all of the women in the study that were treated with crispatus that colonized had greater than or equal to 10 to the 6 CFUs. The gray bars are the proportion of women with detectable CTV05 per week visit. So you can see we were above 80% the first few weeks, and that drops to about 50% at week 24. Another way to look at this is the concentration of lactobacillus in participants who were treated with CTV05. Here are women who were BV negative. You can see that they have high levels of crispatus, mostly over 10 to the 6th, and women who were BV positive have levels less than 10 to the 6th. So that suggests that these higher levels were protective. This is week 12 and week 24, and you can see those levels stay high in women that maintained lactobacillus colonization. When we looked at colonization stratified by sex or menses, we could see that whether women had condomless sex or sex with a condom, the levels of lactobacillus at week 4, 8, 12, and 24 were the same for the two groups. This is women with menses and without menses, again, week 4, 8, 12, and 24. So neither of these situations negatively impacted lactobacillus colonization. Regarding adverse events, all the adverse events were mild or moderate and were equally distributed between the LACTIN-V group and the placebo group, and there were no severe adverse events in either group. This is a qPCR of women that were successfully treated with LACTIN-V. We can see the copies per mil here on the y-axis and pH on the secondary y-axis. So we can see that these women start out with no levels of crispatus or CTV05 shown in the purple and dark purple bar lines. When women were successfully colonized, we can see that all of the qPCR values, whether total bacteria, Lactobacillus, crispatus, or CTV05, track together. And we can see that pH starts out above 5 and drops to 4 in both these women when they're successfully treated with LACTIN-V. Now, here is a woman on the left that was unsuccessfully treated. You can see her lactobacillus levels go up, but they start to decline by week 12 when the dosing ends. And we can see that her pH went down, but then it comes up as Lactobacillus crispatus goes away. And here we have another Lactobacillus, maybe Eners, but you can see there's probably a log more of BV bacteria. So this woman's BV returned. And this is a woman who was treated with placebo. So you can see that she never had Lactobacillus crispatus and she never had LACTIN-V. And you can see she had another lactobacillus that goes up and down, but her pH is very irregular and is high. And again, there's high levels of probably BV bacteria. So in summary of the phase 2b LACTIN-V trial, CTV05 was detectable at protective levels through the 12-week dosing and at 24-week follow-up. Protective CTV05 correlated with a 46% reduction in bacterial vaginosis recurrence. Lactobacillus crispatus levels and placebo arm remain low. They were about 3% versus 79% in the LACTIN-V arm, confirming the need to supplement with exogenous Lactobacillus crispatus. No participant had a severe or serious AE, and LACTIN-V following vaginal metronidazole gel treatment significantly reduced BV recurrence and enhanced Lactobacillus crispatus colonization, and thus had a major impact on the vaginal microbiota towards its optimal state. Some of our proposed next steps: we are working with the Chan Zuckerberg BioHub to do microbiome analysis on the women. These are some very preliminary results. These are women that had BV cures in the LACTIN-V and placebo group. Lactobacillus crispatus is the yellow set of bars. So you can see many of these women start out with high levels of BV type bacteria, Gardnerella, Smithia, Prevotella in these dark purple bars. And then they transition to Lactobacillus crispatus. This woman was considered a BV cure, although it looks like there may be some BV bugs at week 7. Converse that to the placebo arm, where you see only one woman obtained crispatus during that time, and by week 7, most of her crispatus was gone. Most of the other women reverted to Lactobacillus Eners, which is this light green bar, or other lactobacilli. Some additional proposed next steps are to complete and submit our CSC to the FDA and to the Division of Microbiology and Infectious Disease. We'll have discussions with the FDA about a single phase 3 trial with the addition of this phase 2b trial for a new drug application. And we're planning and financing the phase 3 trial to have about 400 to 500 participants at about 10 clinical centers. I'd like to acknowledge all my colleagues who worked very hard in the study. Craig Cohen, pictured here, who ran the study. His right arm, Anke Hemmerling, groups at the STAR STI clinical trials group, Emmis, who did all the statistical analysis, Rupert Call, who's doing cytokine analysis, the Chan Zuckerberg BioHub, and of course the participants who helped out in this study. And that's the end of my talk, and I'd like to thank you very much for listening. I'll take questions.